Welcome to Conversations on Healthcare. This week we welcome Tom Coderre, Deputy Assistant Secretary at SAMHSA, on America's rising substance use and mental health crisis. Now, here are your hosts, Mark Masselli and Margaret Flinter.
May is National Mental Health Month, and this year it's particularly meaningful as new data emerges about the effect of the pandemic on our collective well-being.
Tom Coderre is at the center of the U.S. efforts to recognize and to deal with these issues. He's the Acting Deputy Assistant Secretary for the Mental Health and Substance Use, also known as SAMHSA, the Substance Abuse and Mental Health Services Administration of the United States.
Tom, welcome to Conversations on Healthcare.
Thank you, Mark, and thank you, Margaret. It's great to be with you.
Yeah, we start with grim numbers. The National Center for Health Statistics recently reported that the U.S. had a record 100,000 drug overdoses in 2021, a 16% increase from previous year. And the excess of alcohol drinking increased by 21% during the pandemic. And the Biden administration is implementing a national drug control strategy. And this is the first time the government is prioritizing harm reduction. And that term has been misrepresented by some. And if we can ask you to set the record straight on what harm reduction is all about.
Sure, Mark. Thanks so much for the question. And first of all, let me begin by acknowledging how tragic those overdose deaths that you talked about are. Those are not just statistics, as we know. Those are real people. Those are mothers and fathers and brothers and sisters and aunts and uncles and cousins who have been taken from us way too soon. And the overdose crisis in America is doing that month after month. And it's not just a crisis of one substance. It's really an addiction crisis in our country, as you pointed out. And there are far too many people who turn to substances to change the way they feel because they've lost hope or they are self-medicating for some underlying condition that they may have. Let's just talk a little bit about harm reduction, because really that approach is really all about saving lives. Harm reduction is proactive and it's evidence-based. It's to reduce the negative personal and public health impacts of any behaviors that are associated with alcohol and other substance use. And it works at both the individual level and the community level. And it's, as you pointed out, a very important part of the Biden-Harris administration's comprehensive approach to addressing the crisis that we're in the middle of through bringing prevention, treatment, and recovery services to individuals where they are to help them work through their own goals, to help bring them across the stages of change from somebody who may be pre-contemplative to contemplative to some type of action and maintenance. Harm reduction incorporates a whole spectrum of strategies, again, to meet people where they are on their own terms, and it serves as a pathway to additional prevention, treatment, and recovery services through really something that I think is important. It's engagement, right? That's the thing. That's one of the missing pieces often to the puzzle, is that you don't just set up treatment and everybody shows up in treatment and gets well. It's a process of engagement, as I talked about, bringing people across the stages of change and helping them try to find out what their goals are in life, addressing the broader health and social issues through improved policies, programs, and practices.
Well, Tom, thank you for that. And this is kind of a technical question maybe, but I think it gets to the importance of the program SAMHSA funds. I'd like you to explain to our listeners the Government and Performance Results Act tool, which I understand is, I know, but good to understand. I know it's required of all programs that SAMHSA funds. We've read that it's used to assess addiction program performance, but it's got some critics that say it's overbearing. And the questions it asks people, we always worry about things that might be, disincentives to people to participate. What is this act and the tool, and what's your thoughts on this?
Well, thanks for asking, Margaret. It's a law that was enacted a long time ago, back in 1993, and it's one of a series of laws that's really to improve governance, performance management. Of course, the taxpayers are investing lots of money into these government programs, and they want to make sure that they're working, that they get results from them. So GIFRA requires agencies to engage in performance management tasks such as setting goals, measuring results, and reporting progress. And to comply with GIFRA, agencies produce strategic plans, performance plans, and conduct what we call gap analysis of projects. And as part of this federal mandate, all of our SAMHSA grantees are required to collect and report performance data using approved measurement tools. And what we noticed is that many of these tools, as you pointed out, and we heard this from our stakeholders, that they needed some relief from some of these tools. So how can we meet them where they are, because they're doing important work in the community, they're saving lives, they're offering effective prevention, treatment, and recovery services. So what we did is we heard the objections to certain questions in the survey. We have the ability every few years to update those questions, and that's exactly what we did. We embarked on a process to do that. So we have a new revised GIFRA tool that's going into effect on October 1st, the start of the new fiscal year. And the revised updated questions for the tool were previously made available to the public as part of, we have a 60 and 30-day federal registry process through OMB that we have to follow. People were able to make public comments, and we heard from academicians, we heard from treatment professionals, harm reduction specialists, tribal communities, people with lived experience, and lots of other stakeholders. And the public comments were reviewed, and we have the new tool as a result, and the new questions as a result of that. So hopefully folks will be seeing that in the coming fiscal year, and that will reduce some of the burden that folks felt in the past.
Tom, speaking of seeing things, what a great perch that you have at SAMHSA as part of the U.S. Department of Health and Human Services, which engages with community partnerships, connects people to innovative and evidence-based practices. I'm wondering what you could share with us about the excitement that's going out in the field, some of the best practices that you're seeing around the country.
Well, thanks for that question, Mark. SAMHSA has, as you all know, an evidence-based practice resource center. We have it on our website. It's available to all. And we have a way to really be able to share and lift up some of the most significant evidence-based practices that are happening around the country. Mm-hmm. So we have things like practical tools for prescribing and promoting buprenorphine in primary care settings. We have information about prescription stimulant mix use among youth and young adults. We have a guidebook on preventing marijuana, treating concurrent substance use, telehealth, which has obviously been a big deal during the pandemic when everyone had to move to virtual platforms, and even things like reducing vaping among youth and young adults. So we've seen lots of these evidence-based practices being employed around the country, and we're happy to be able to lift those up. We also, just to give you some more specific information, have seen practices like, around buprenorphine training requirements and peer aids. Some of you may know, and your listeners probably do as well, is that at the start of the COVID pandemic, we had to relax the training requirements for practitioners who wanted to treat people who had an opioid use disorder, removing that barrier that existed. As a result, we've seen more eligible practitioners sign up to be able to prescribe buprenorphine, which is an urgently needed medication to help people on their treatment pathway. Equally important are peer recovery aids, people who share their own journeys and strategies with others who are grappling with their own cycles of substance use, and peer supports play a really important role in the work of recovery. So we value their contributions to this space. We also just embarked on a listening session. Our Center for Substance Abuse Prevention, in collaboration with our regional offices and our stakeholders, had a series of listening sessions last year. And we learned that for some organizations, the pandemic was an opportunity to be innovative in their use of technology, to go beyond their existing practices. One organization, for example, developed a mobile app through which individuals could connect with a confidential crisis phone line, chat with professionals in the crisis intervention unit, and obtain prevention materials. So that was an important tool. And lastly, many of you know that we're transitioning our National Suicide Prevention Lifeline to a new 3-digit number, 988. And so as we do that transition, which we're going to launch in July, we see that as a first step toward a transformed crisis system in America, which of course is pretty innovative. We're making $282 million investment to the transition to the Lifeline. But the implementation is going to depend significantly on our partners and our stakeholders at the state, tribal, and local levels as we seek to help transform what historically has been an underfunded and fragmented system. So we value the support and contributions of our partners at the community level when we're making these innovations.
Right.
Well, there was a lot in your comments there, Tom, and just want to emphasize how appreciated and valuable the changes to the training requirements were, and that at the community level, everyone's certainly focused on getting the information about the crisis number out to the public. So thank you so much for your work on
Margaret.
that.
No, thank you for that.
And I want to go back to data for a moment, but it's data in the interest of the most critical issue, which is preventing these fatal overdoses. We know that the best predictor, perhaps the best predictor of a fatal overdose, is a prior non-fatal overdose. That's why we so prioritize anyone seen in the ER, brought in by the EMS folks, and getting them started on treatment. But there isn't a way to measure non-fatal overdoses overall. Are there some improvements on that data front? Do you have any initiatives in the work for that so that we can do a better job of preventing the fatal overdoses?
Yeah, this is a really difficult question that you raise. And the reason it's really difficult is because, of course, there are non-fatal overdoses that happen that we know about because law enforcement responds or EMS responds or somebody ends up in an emergency room. But then there's a lot of fatal overdoses, non-fatal overdoses that we don't know anything about because we have deployed so much naloxone into communities that it's really hard to track when somebody has a non-fatal overdose there. So that data becomes really difficult to collect. We're lucky that we have things like OD map, which first responders use to enter data in real time into a system so that law enforcement can help track across counties, states, and other jurisdictions where there are hotspots so that they know if something's happening and then they can respond immediately. SAMHSA has our system called DAWN, our Drug Abuse Warning Network, because we agree that non-fatal overdose data holds value in providing public health surveillance. So our DAWN involves a network of hospitals providing us data about patients who present to their emergency departments with conditions related to substance use. So we can hopefully get a little bit ahead of this because other surveillance tools that we have, like our flagship NISDA, our National Survey on Drug Use and Health, that data lags behind. And by the time we get that data, it's oftentimes, it's helpful for policy decisions into the future, but it's not really helpful in real time to help us respond. One of the things that I think we really have to do here is work with state and county level folks, because a lot of these things, these systems have to be employed there. We have state laws and we have county coroners and we even have municipal rules that are in place that these partnerships have to be developed, and perhaps SAMHSA has a role in helping to provide resources to get these data systems up and running around the country so that we can get a better sense of when these non-fatal overdoses happen so we can respond more quickly.
Tom, I think it's fair to say that there's no margin in making enemies when we're trying to do such important work and to save lives of individuals and all across the country. And we see the Biden administration stresses the word unity and highlights bipartisanship in this effort. But there are disagreements, and Republicans in states such as West Virginia and Indiana have shut down needle exchange programs. Donald Trump's Surgeon General recently said Republicans are more likely to believe addiction is a moral failing than a treatable disease. How do you balance all of these, and what do you say when you hear people express these views or take these actions?
Well, I'm not a political appointee anymore, Mark, so I really don't offer opinions on politics. However, we are in a polarized moment in our history, so we have to be careful that doesn't seep into this space and get in the way of us helping advance behavioral health and save lives. But what I do know is that for mental illness and substance use disorder, it's probably the one issue on Capitol Hill and in state houses where there's the most bipartisan support. Mental illness and substance use disorders don't discriminate. They don't have party labels, and Congress is working together to provide resources to the American people that are so desperately needed. So there'll always be disagreements on the margins, but on the big things, there's a lot of agreement and there's a lot of people working together. Of course, SAMHSA's priority is connecting people to effective treatments and supports because we know that recovery is real and it's possible for everyone.
Well, Tom, I think it's safe to say that none of us believe you could really put a dollar figure on the total cost of the opioid crisis to the United States. I think it's incalculable in some ways, but the experts say maybe $1 trillion each year. And there's a recent financial settlement with the Sackler family, which controlled Purdue Pharma, the maker of OxyContin. And that settlement, I believe, is $6 billion, which is supposed to be devoted to addressing the epidemic. We all remember the tobacco settlement money and certainly some criticisms that there was too much lost opportunity to really curb smoking with those funds. How do we do our best in this instance to ensure that the money funds what we have evidence really works as a strategy to reduce, hopefully, of course, eliminate overdose from opioids?
Yeah, that's a great question, and it's on the minds of so many Americans, especially people who were harmed by companies who had a moral obligation to be good stewards of these products, and so that will get decided in courts. That the settlement really falls outside of SAMHSA's purview. And there are plenty of outside groups who are looking at this and they're making recommendations. Resources, of course, are super important, and we need to continue to have the resources we need to make sure that we can expand the full continuum of care for people. I know that Georgetown University recently held a roundtable with people from all parts of the field to get their opinions about how these resources should be spent. And that concern that you raised was raised at that time too, to make sure that these settlement monies go to things that really help mitigate the ongoing crisis. But what I can say about SAMHSA is that we have a budget request into Congress of more than $10 billion. And with this urgent need being faced throughout the country and throughout our communities, we need that money more than ever. Programs funded by SAMHSA, which prioritize connecting people to treatment for substance use disorders and mental health conditions, have never been as crucial as they are now, especially given the toll that the COVID-19 pandemic has had on all Americans. We've seen an exacerbation, right, of whether it's people who had mild anxiety and depression, now it's moderate or severe. We've seen substance use continue to rise, as we talked about earlier. And so these resources really will help us connect people to the help that they need.
Well, both of them are very important, certainly fully funding SAMHSA's request. And if there are additional dollars coming through the settlement, that will be good news. But there is hope. And you've testified before the Senate that there are at least 22 million Americans who've resolved their issues with addiction, but there are so many routes as well to that recovery. What does the research tell us about what works right now?
Well, there's a lot of evidence about what works, and I was really proud to be involved when I was a political appointee back in the Obama administration on a 2016 Surgeon General's report on alcohol, drugs, and health. And for those of you who are familiar with Surgeon General's reports, they review the current evidence. And that report had several chapters, one on neurobiology, one on prevention, one on treatment, one on recovery support, and one on health systems that really walked through. And for anyone who's listening and you want to check that report out, it's still very valuable. And even though it's a couple of years old, it's pretty timely. There's no cookie cutter approaches to treating substance use disorder. It's very individualized, and SAMHSA's role is to make sure that there are multiple entry points to effective evidence-based treatments and recovery supports. There are also, as you pointed out, many pathways. But to be clear, a lot of times people conflate a 12-step group with clinical treatment. And the two are very, very different. There's a big difference between the two. One really is about managing one's symptoms of their substance use disorder. And the other one is a peer support that extends beyond those acute symptoms, right? When we talk about addiction being a chronic condition that needs to be managed over someone's lifetime, that's really where 12-step groups and other peer support related activities, which I have been the beneficiary of myself, and we might have an opportunity to talk about that today, where they come in and then they can help that person sustain their recovery for the long term. And I think that's really important.
Well, Tom, many of us have read the sad story over recent days in the media about the suicide of country singer Naomi Judd. And she spoke very publicly for years about her struggle with depression. And she referred to it as, and her family did, I believe, as treatment-resistant depression. I wonder, are you worried that this leaves people thinking that that means there are no options if they have this diagnosis? And I'll add that Dr. Tom Insel just told us last week in the field told us what we know in the field, that there are still options, even if someone carries this label of treatment-resistant depression. What's your thoughts on that? How does that land with the public?
Yeah, well, first of all, about Naomi Judd, that's, her story is heartbreaking to me and many, many Americans. I couldn't believe it when I heard the news that one day before she was about to be inducted into the Hall of Fame, Country Music Hall of Fame, that she succumbed to her illness, and that was tragic. And of course, I can't speak to her personal diagnosis because I'm not really familiar with it, but at SAMHSA, it's really our role to promote options as broadly as we can and to seize every opportunity to make sure that people know where to look and to get connected to treatments and supports. We know recovery is possible, it's real, it's for everyone. And so my message would be not to lose hope. I think, when people talk about there being no options, that is not what you want to say to somebody who's suffering from mental illness. There are always options. There's always hope. There's always support. There's always something else to try. So we cannot give up on any individual, and we can't be sending the message to any individual that we don't have the support that they need.
Tom, you talked a few minutes ago about your own journey, and you've been very open about sharing that, and it's very inspiring to those of us who have heard it. But I'm wondering if we could ask you to share what you'd like so others can learn and better understand the journey that people go through to get on the other side.
Well, sure. I mean, thanks so much for asking that. We're taping this on May 16th, and yesterday, May 15th, was my 19th recovery anniversary, believe it or not, just yesterday. So for me, this is personal. I'm passionate about it. And recovery has saved my life and actually given me a life that beyond my wildest dreams that I could never have imagined. I went through a very public battle with addiction. I was a state senator from Rhode Island. I served 8 years in the state Senate. I developed an issue with alcohol and other drugs. and it ended up costing me everything. I ended up losing my position in the Senate. I lost my job as a nonprofit executive. My family and friends tried to help. I resisted their help. I pushed them away. That caused me to lose them. And eventually, that hope I spoke about earlier, I lost that hope. But fortunately, I was able to get the help that I needed. And today I'm a person in long-term recovery, which for me means I haven't used alcohol or drugs since May 15th of 2003. And I've been able to not just create a better life for myself, but I've been able to create a better life for my family and ultimately my entire community, because that's what happens when people find and sustain their recovery. I had access to a long-term residential treatment program, psychiatric services, which I needed, and then what SAMHSA likes to call the 4 dimensions of recovery: health, home, purpose, and community. That's how we build a life in the community for everyone, by making sure that the social determinants of health are not ignored, that people have access. I was able to go back to school and finish a bachelor's degree. I was able to get employment, eventually reemployed. I was able to get my family back in my life. That family I said I pushed away and resisted their help, they came back into my life. My mom, my dad, my brother, my sister, my nieces and nephews got to have their family member back. And that was critically important for me as well. And so I've been really fortunate to be able to get into this space and match, my love for politics and public policy with my passion for recovery and being able to help other people find what I've found. So it's been a truly a blessing and something that I'm so excited about.
Well, Tom, thank you for sharing your story. Thank you for your service to the country and for your leadership in this most critical area that our country faces. Lots to do, and we join you in your fight. And
thank you. We need all the help we can get. Thank you, Margaret. Thank you, Mark.
Yeah.
Thank you also to our audience for joining us today. And you can learn more about conversations on healthcare and sign up for our email updates at www.chcradio.com. Tom, thank you so much again for joining us today.
Thanks for having me.